Welcome, everyone, and thank you for joining us today. Before we begin the webinar, Osteoporosis Canada acknowledges the land that our offices located in Toronto are on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. My name is Tracie Napoli, Director of Fund Development and MARCOM at Osteoporosis Canada, and I will be your moderator for today. This presentation will provide general information and is not intended as individualized health advice. If you have questions about today's topic, please consult a physician. Now, during the webinar, if you have a question, you can click the Q&A icon at the bottom of your screen and enter it there. At the end of the presentation, we will do our best to answer as many questions as we can during the webinar within the time available. Osteoporosis Canada is the only national organization serving people affected by osteoporosis, working to educate, empower, and support individuals and communities on bone health and in the risk reduction and treatment of osteoporosis. We look to the best experts to inform our care guideline for patients and care providers. Our Scientific Advisory Council is made up of experts from across the country in osteoporosis and bone metabolism, and it's a volunteer membership. Comprised of clinicians, researchers, and educators, the SAC advises Osteoporosis Canada's board and staff on scientific and medical issues. Osteoporosis Canada provides medically accurate information to patients, healthcare providers, and the public. Services include programs and support groups, educational webinars like this one, podcasts, digital tools, and resources available at osteoporosis.ca, along with community resources. Today's webinar topic is menopause, which is associated with a range of symptoms which may affect quality of life, as well as may increase an individual's risk of chronic conditions such as osteoporosis or cardiovascular disease. During the webinar, we will discuss evidence-based information on perimenopause, menopause, and post-menopause, how each affect the body, increased health risks, dispelling myths, treatments, and more. I am now pleased to introduce our presenter for today's webinar, Dr. Nese Yuksel. Dr. Yuksel is a full professor with the Faculty of Pharmacy and Pharmaceutical Sciences at the College of Health Sciences at the University of Alberta. Additionally, Dr. Yuksel holds a cross appointment with Alberta Health Services, and has been practicing in the areas of menopause and osteoporosis for nearly 25 years. Dr. Yuksel is a Menopause Society certified practitioner and is the current president for the Canadian Menopause Society. She is also a member of the Osteoporosis Canada Scientific Advisory Council and the current chair of the CPHA Editorial Advisory Committee. It is my pleasure to now welcome Dr. Yuksel.
Thank you so much, Tracie. I'm just going to share my screen and we'll get started. Give me 1 second. Hopefully that works and everyone can see this okay. It is such a pleasure to be here, to be talking about menopause, what you need to know. Thank you to Tracie and Osteoporosis Canada for inviting me to present this webinar. I'm a proud member of the Scientific Advisory Council with Osteoporosis Canada for many years, so it's a real pleasure to be here. I've been involved in the area of menopause and osteoporosis for almost 25 years now and was practicing in a menopause clinic in Edmonton until last year, and I still continue to practice in an osteoporosis clinic in Edmonton. And as you heard already, I'm the president of the Canadian Menopause Society, so it's my pleasure to be here. So what I hope to do by the end of this webinar is be able to give you an appreciation why we should care about menopause. I hope to also give you an appreciation for the challenges that women face, review the stages of menopause, describe common menopause symptoms and some of the long-term risks. And we're going to spend a little bit of time talking about menopause symptoms, discuss options for menopause management. And I do want to spend a bit of time talking about the role of hormone therapy and our current thoughts on it. Describe what you can do to have a healthy menopause, and that's how we're going to end. So, throughout this presentation, I want to acknowledge that the term woman is used, but do understand that the symptoms of menopause can affect all individuals who experience menopause, even those individuals who may not always identify as women. So, why should we even care about menopause? Well, menopause is common. Menopause affects 50% of the population. It is anticipated by the year 2030 that over 1 billion women will be menopausal worldwide. And this represents about 47 million women becoming menopausal every year worldwide. In Canada, over 5 million women are menopausal or perimenopausal at this time. And you probably know that menopause is having its moment. Everywhere you turn, there is an article on menopause, especially this last year. There were several episodes on the National and CBC News. Chatelaine did a whole series of articles just recently. And, I would say it's about time. It's about time we're talking about this. And I'm happy that Osteoporosis Canada is doing this webinar as well, bringing awareness. So let's talk a little bit about what women are facing. And women face a lot of challenges. There's stigma towards menopause, and there's stigma towards aging. We don't like to see women aging. Society devalues women as we age. And women are especially vulnerable during this time. They could be suffering from hot flushes and sleep issues and mood issues, and they're looking for solutions. And we know there's a health gap in menopause. Currently, there is limited access to menopause care. There's only a few specialty clinics across Canada focusing on menopause. And women aren't getting the access they need. And there's some reasons for this. One is still there's fear about use of hormone therapy, and I'll talk a little bit about that. There's also comfort level with menopause by primary care providers, and there's also time limitations. The time needed to adequately assess and educate women is not always there. So, what are women telling us? And these are some of the common things we hear. These may also resonate with you. I do not understand what is happening to me. Why is no one talking about it? And we are talking about it now, but why is no one talking about it? Is this all in my head? I am fearful of hormones. Where can I go for help? I feel so alone. And as I mentioned, these may resonate with you too. There is a gap with menopause care in Canada. The Menopause Foundation of Canada recently came out with a report on the silence and the stigma of menopause, and you may have seen this. In this report, they highlight a survey they completed of over 1,000 women in Canada. This survey results showed a significant gap in menopause care. 54% of women who took the survey indicated that the topic of menopause was still taboo after all these years. 1 in 2 women did not feel prepared for menopause, and 55% wish they had learned about it earlier in life. And one of the complicating factors is the misinformation out there. Everywhere you turn, there's misinformation. There's a new product, device targeting menopausal health, from pellet therapy to vaginal steaming. I'm sure you've heard of these, to jade eggs, to natural hormones. No wonder it can be overwhelming for women. Where do we even start? And misinformation is an issue. It's a huge issue. Misinformation can stop women from getting effective menopause treatment. We are seeing this more and more. This is an article from Australia, but we're also seeing this in Canada as well, where there's such an underuse of effective menopause treatment. So let's talk about the impact of menopause. Well, menopause symptoms are common. Vasomotor symptoms, and these are hot flushes and night sweats, can occur in more than 75% of women, with 25 to 30% of individuals having severe enough symptoms that they need to seek treatment. Now, the duration of symptoms is longer than we previously thought. The data now indicates that the duration is of about 7.4 years. And that's because a lot of women start experiencing those symptoms in perimenopause, and I'll talk about that, with the median duration of about 4.5 years since their final menstrual period is the time. But in some women, it may be even longer, 10 years or more, especially if it starts earlier in that menopause transition. Now, these symptoms are well documented to negatively affect quality of life. Many studies have shown this, especially, think about it. If a woman is having a lot of night sweats, sleep issues, mood issues, well, that's going to affect daily function. And there's been recent attention about the effect of menopause on work productivity. Last October, there was a report from the Menopause Foundation of Canada showing the impact on work. They estimated that unmanaged symptoms of menopause cost the economy $3.5 billion per year. This is staggering. And it's from lost productivity, lost days of work, and lost income. So let's take a step back and talk about the stages of menopause. Let's first define it. What is it? Menopause is a natural process. It's just the normal aging of the ovaries, and you start seeing a decline in estrogen and progesterone levels. Now, menopause can also be induced from surgery when both ovaries are removed. Also, it can be from medical interventions such as chemotherapy or radiation for cancer treatment, for example. So, menopause is defined as the end of periods, so the last menstrual period. However, we diagnose it looking backwards. Uh, Menopause is diagnosed after 1 year, so 12 months without a period. Then someone is determined as being menopausal. Now, the time leading up to the menopause, so that last menstrual period and up to that 1 year later, is called perimenopause. And this is a time where estrogen levels are fluctuating. You can see up and down levels, as you can see on this graph. This is where a lot of symptoms can happen, actually. And any time after the menopause, once that is diagnosed, is called post-menopause. The average age of menopause in North America is 51 years of age. However, there's a real range from 45 to 55 years. Now, I get a lot of questions about perimenopause. So I've added in this slide, perimenopause can start 4 to 10 years before that final menstrual period. So it can happen in a lot of times it's in women in their 40s when you start seeing symptoms of perimenopause. And this is a time of hormone fluctuations, as I mentioned, leading to a lot of the symptoms. Menstrual periods can also be changing. They can be heavier or more frequent, or lighter or less frequent. However, I just want to mention that symptoms can happen even without menstrual periods changes, or vice versa. Menstrual period changes can be happening without any symptoms. Now, women will have their own unique experience going through menopause, and that's because of the variety of types of symptoms that one can see. And we'll talk about that next. So, let's talk about the common symptoms and some of the long term health risks. Now, there are estrogen receptors throughout our body. There's over 200 estrogen receptor sites throughout the body. So, no wonder it affects so many different areas of our body when we start seeing hormone fluctuations or lowering of estrogen levels. And this is why we see the symptoms. There's been more than 34 symptoms associated with menopause. Let's talk about some of them. And I want to focus on a few key ones. The most common symptoms are vasomotor symptoms. Those are the hot flashes and night sweats. And these symptoms can range from very just mild heat to intense sweating. And women can feel palpitations, dizziness, and anxiety during those hot flushes or night sweats. They often start in the perimenopause, as I mentioned. And we do know that our internal thermostat is affected by the estrogen levels fluctuating or the fall in levels. Now, there's a new mechanism that's been identified that causes hot flushes. So we're finally figuring out physiologically why we're having hot flushes. When estrogen levels fluctuate or fall, they actually cause an overactivity in the brain, in neurons in the brain called candy neurons. And this can lead to a hot flush. Now, what's really exciting is there's new drugs being targeted to treat this mechanism. And these drugs have already come out in other parts of the world, and they'll be coming to Canada as well soon. Now, sleep is a huge issue. Sleep issues can, include fragmented sleep, especially if you're having a lot of night sweats that are waking you up. Can also affect that deepness and quality of sleep, especially not having enough estrogens and difficulty staying asleep. So the most common things I hear from women is, I woke up at 2 or 3 in the morning and, I just can't go back to sleep. Of course, it's going to make, you're tired and fatigued and affect your moods during the day. But just one comment I want to make is that not all sleep issues are from menopause. Sleep issues are common in midlife in general. They could be due to other reasons, such as sleep apnea or another sleep issue that just needs further investigating. And what about mood issues? And mood issues are very common. It's really especially common during the perimenopause when those hormones are fluctuating. And estrogens are really important because they regulate your serotonin and help regulate your moods. Progesterone can also be important too. And common symptoms include irritability, anxiety, depressive episodes, and mood swings. And it's been reported that up to 50% of individuals will have some depressive issues during that time. And what about cognitive issues and brain fog? And we don't talk enough about these issues. The feeling of that brain fog, the concentration is real. It's more of an issue during the perimenopause, we find, and it can lead to a loss of confidence where you just don't feel confident in what you're doing because you can't think of the words or you just feel very, very foggy. Usually, for most people, it is somewhat on the mild side and does improve with time. I do want to reassure you it's nothing to fear. It is not a risk for dementia later in life just because you're having some brain fog. I wanted to spend a couple of minutes talking about other changes in menopause. And one of the changes I want to talk about are vaginal changes. And we just don't talk enough about this as well. Um, this is now called genitourinary syndrome of menopause, or GSM. And on this slide, you can see the effects of low estrogen levels on causing vaginal changes, causing vaginal atrophy. So basically, you can see on this part of the slide that in a healthy vagina, you can see normal vaginal tissue. The vaginal lining is good. There's blood flow to the area. What happens with loss of estrogens is there's a thinning of this lining and there's less blood flow to the area. So this causes a lot of the vaginal dryness symptoms that can be seen. So common symptoms can be vaginal dryness. This can result in painful intercourse, but also you can see recurrent bladder infections with changes in the pH in the vagina. Also urinary incontinence and low libido as well. And so this can have a number of effects. There are a lot of other symptoms of menopause too that you should be aware of. Things like muscle and joint aches can be very common too. Fatigue and lack of energy, especially if you're not sleeping. Bloating, breast tenderness, migraines and headaches, also more common in perimenopause when those hormones are fluctuating. Even things like tingling extremities, like the tingling underneath the feet, or the burning mouth or the tongue, these are all reported symptoms. We don't always recognize them either. And even dry eyes are all symptoms. So let's talk a little bit about long-term health consequences with loss of estrogens. Let's talk about heart health first. And most common cause of death in women, as you know, is cardiovascular disease. Cardiovascular disease will cause 1 in 3 deaths in women each year. Now, estrogens have a protective effect on the blood vessels, especially before menopause, when we have the estrogen in our bodies. What it does is it prevents the buildup of the atherosclerosis in this intimal layer of the blood vessels, as you can see in this slide. So it will prevent that. With the loss of estrogen after menopause, it doesn't have this protective effect anymore. And this is where the risk of heart disease increases after menopause. And what about bone health? Well, this picture shows the change in bone density as a woman ages. This is spinal bone mineral density. And as you can see, it's in women as well and men on here. Um, the picture shows that we develop our peak bone mass around the ages around 25 to 35 years of age. And We can start seeing some bone loss during perimenopause. So women can start seeing it around perimenopause when those hormones are starting to change. But at menopause, there is a dramatic decline in bone density from the loss of estrogens. The greatest decline is for that first 10 years from the final menstrual period, and females can lose up to 2 to 3% of their bone density each year for those 10 years. Then after that, after the 10 years, then there's a more gradual decline, which is just due to aging. And you can see the slope is very similar to men. Now, what I also wanted to talk about was that estrogen loss can affect both bone and muscle. We have estrogen receptors not only on bone, but also on muscle. And this slide summarizes the effect of estrogen loss on the bones. We see a decrease in bone mineral density, decrease in bone quality, which can result in more fractures, but it also can affect muscle. And estrogen loss has a number of effects on the muscle. It's a lot more detailed than I have time to get into, but it can decrease muscle mass and it can decrease muscle strength and power. And so it's really important to also be thinking about your muscle and strength training and some of those types of exercise during that time. And I will talk a little bit more about that. So, what options are there to help my symptoms? And I'm going to focus more on options to help menopause symptoms. And so on this slide covers the treatment approaches for menopause symptoms. And this is based on the Canadian guidelines for menopause. I was one of the lead authors for one of the publications for the guidelines. The options include lifestyle measures, menopausal hormone therapy, non-hormonal prescription options, and complementary therapies. I will talk about each of these. Now, this is just a brief overview as we only have so much time today. So it's just to kind of give you an appreciation for each of these areas. So let's talk about lifestyle measures. And lifestyle measures are really important. They can help manage your symptoms. And these include things like cooling techniques, such as dressing in layers, wearing breathable clothing, avoiding triggers such as hot environments, hot foods, alcohol. Getting regular exercise also really helps. Yoga and relaxation techniques just to help with stress reduction. Weight loss and maintaining a healthy weight is also very important. And finally, if you are a smoker, stopping smoking is really helpful. Women who smoke may have more issues with menopause symptoms because smoking actually increases metabolism of estrogen. So women who smoke can go into menopause or at least start having symptoms earlier. And as we know, it's not good for the bone health as well. So let's talk a bit about menopausal hormone therapy. What is it? Well, we call it menopausal hormone therapy or MHT. It's going to be MHT on my slides. But you may also know it as hormone replacement therapy or HRT or just hormone therapy. Now, these refer to the same thing. Hormone therapy replaces some, but not all the hormones that the ovaries made before menopause. And this includes estrogen and progesterone. Now, we will need estrogen and progesterone. Both are given. The estrogen helps with the symptoms, and the progesterone helps prevent the buildup of the uterus lining. And estrogen alone is given for women who have had a hysterectomy. They don't necessarily need to be on progesterone. So, what is the role of hormone therapy? The guidelines indicate that hormone therapy is the most effective option for hot flushes and night sweats, especially if they're bothersome, if they're moderate to severe or they're feeling them bothersome. It's a good option, and it's actually the most effective based on studies. And it does have other benefits as well. It can improve sleep and the deepness of sleep. It can help contribute to mood and help with mood and well-being. It can improve vaginal symptoms and it can prevent bone loss and fractures as well. But why is there still a fear with the use of hormone therapy? Why are we still fearful and why is it not used very much? I think people are feeling more comfortable with it again, but why is there still that fear out there? So, this was an excellent article in the New York Times last year, and you may have seen this. And this article discusses how women are being misled about menopause and why more women aren't using proven therapies like hormone therapy. Now, a lot of this stems from the large study that was published, the Women's Health Initiative, or WHI, and I'm sure you've heard of it, that showed an increased risk of heart attacks and breast cancer in women on hormone therapy. And that was the combination of estrogen and progesterone. However, let's talk about the disservice to women with the WHI. The problem is that the media overemphasized these risks. Now, the initial results were published in 2002. The study was in women who were older. The average age was 63 years to start hormone therapy because they were looking at more prevention of cardiovascular disease and other effects versus symptom improvement. So these women were not symptomatic. Unfortunately, what happened is this was generalized, the results were generalized to all women, even younger women who are symptomatic, who may be in their 40s and 50s, perimenopausal or just, recently menopausal. This is a very different population. Many studies since 2002 have actually provided a lot of reassurance about the safety of hormone therapy in the right women, in right population of women who are symptomatic. However, the fear has never really fully recovered, and many women and healthcare providers are still fearful about use of hormone therapy. So let's talk a bit about what the guidelines say. What do the current Canadian guidelines say for hormone therapy use for menopause symptoms? Hormone therapy is considered safe to start if you are less than 60 years of age or are within 10 years since your last menstrual period. And I think what's really important about that is actually more the 10 years since your last menstrual period. And you have no contraindications to hormone therapy. And I'll talk a bit about those contraindications. Hormone therapy is individualized to your needs. Kind of symptoms are you having? What risk factors you may have. So, what kind of conditions do you have? What other medications may you be on? As well as what your preferences. And luckily, we have a number of options. I did want to spend a moment talking about the Osteoporosis Canada guidelines. And as you know, that the Osteoporosis Canada guidelines came out last year, late last year. And I don't have a ton of time to go over these because we're focusing on menopause in this session. But I did want to mention about what they say, the guidelines say for postmenopausal osteoporosis and if they recommend hormone therapy. And for postmenopausal osteoporosis, bisphosphonate therapy is still first line for people who need osteoporosis medication. So if you're high risk or have risk factors for fractures and you need osteoporosis medication, the recommendation is bisphosphonate therapy, either oral or IV. However, hormone therapy can be considered for postmenopausal females with menopause symptoms. So if you're needing it for menopause symptoms and you are less than 60 years of age or less than 10 years since your last menstrual period, so same as my previous slide, and you have no contraindications, it can be an alternative to bisphosphonates. So I just wanted to mention that. Now, I also wanted to highlight about early or premature menopause. Early menopause is before the age of 45 years, and premature is before 40 years of age. Now, these women are at an increased risk of osteoporosis, heart disease, as well as cognitive impairment in later in life. As well, they are an increased risk of early mortality. And the younger that a woman goes into menopause, the greater these risks are, because normally they would have estrogen during that time, and in not having enough estrogen, that's going to put them at risk, right, for these conditions. So hormone therapy is needed as prevention to avoid these risks and should be used until the average age of menopause, around 51 years of age. So who should not use hormone therapy? And some individuals will have conditions which would be contraindications to either estrogen or progesterone. And these are the contraindications from the guidelines. So for estrogen, any undiagnosed abnormal vaginal bleeding, history of breast cancer, history of estrogen dependent cancers, blood clots, coronary heart disease, stroke, or liver disease are all contraindications. And contraindications to progesterone include undiagnosed abnormal vaginal bleeding as well as history of breast cancer. Now, luckily, we have a lot of options for hormone therapy. These are the estrogen products. We have oral tablets, we have transdermal products such as patches and gels, and we have vaginal estrogen products. The vaginal estrogen products are only local effect and are used primarily for vaginal dryness and some of those GSM symptoms, as I mentioned. What I wanted to highlight is the types of estrogen found in these products. Most of the products contain estradiol. Now, estradiol would be considered bioidentical. And if you look at the definition of bioidentical, this means any hormone with a similar chemical structure to the human body hormone. I wanted to mention that many commercial products contain bioidentical hormones. And what about progesterone products? And we have lots of progesterone products as well. Most commonly used progesterone products are the oral products, but we also have combination products with transdermal patches and an oral product. So this is combination with an estrogen and a progesterone. We can also use intrauterine device containing progesterone, and such as Brenna is a product like that. And we also have a bioidentical progesterone, which is micronized progesterone on here. And we have other hormone therapy products as well, which I just don't have time to get into, but we do have a number of options. I did want to spend a minute talking about vaginal estrogen therapy, as I get many, many questions about this. Vaginal estrogen therapy is a really good option for vaginal dryness or frequent bladder infections, for example. It can prevent frequent bladder infections. It is the preferred route if you only have GSM or vaginal symptoms. These products include vaginal tablets or ovules, there's vaginal creams, and there's a vaginal ring. Now, think of these as mainly local effects, and they have very little systemic absorption into the body because there's very little small doses being used. They do not have the same risks as other hormone therapies, so should not be considered the same. So those contraindications that I mentioned, they're not the same contraindications for vaginal estrogen therapy. And so they do not require progesterone as well. So let's look at more of the systemic hormone therapy when we're trying to make a decision if we want help with our, vasomotor symptoms or sleep. What do you do when you're trying to decide on hormone therapy? So again, it's the benefits to risk. What kind of benefits are you going to see based on the types of symptoms you're having? You can see improvements in hot flushes and night sweats, sleep, mood. These can all improve as well as vaginal symptoms, can help prevent bone loss and fractures. And then we always have to look at risk of any medication that we're taking. We know that there's an increased risk, but these are rare. And I'm going to talk a little bit more about these: heart disease and blood clots and breast cancer. And we'll talk a bit about those. And then side effects. Now, I don't have as much time to talk about side effects, but I'll just mention quickly the most common side effects that women see could be some vaginal bleeding when they first get started, could be water retention, breast tenderness, and headaches can happen. Usually it does get better with time. So let's look at some of these risks. Let's look at the risk of cardiovascular disease. What's really important is age and time since menopause matters, and I think especially time since menopause. The risk of heart disease with hormone therapy increases when it's started after age 60 years or if someone is more than 10 years after their final menstrual period. And this was shown in the studies. This is where that criteria comes from for when to start hormone therapy. Now, we need to avoid hormone therapy if you have had a blood clot already or have had a heart attack or heart disease already. We would avoid it. And if you have risk factors, for example, high blood pressure, or you're a smoker, or you're a diabetic, what we would do is consider transdermal products such as a patch or gel for the estrogen, and using lower doses as well. And the reason we might use a transdermal product is because the estrogen bypasses the liver when it initially gets absorbed through the skin. And so it may be a little safer for preventing, not having the same risk, not preventing, but not having the same risk as the blood clots with oral doses at the same doses. What about breast cancer? And this is the most common worry women have about using hormone therapy. I do want to reassure you that the risk of breast cancer is quite low. The risk of breast cancer is less than 0.1%, which is less than 1 per thousand women per year for the combination of estrogen and progesterone. This is what the results of the Women's Health Initiative has shown. This would be considered a rare category by the World Health Organization. Also, not all the hormone therapy is the same in regards to breast cancer risks. There may be differences in risk with the type of hormone therapy. For example, when with estrogen alone in women without a uterus, it didn't have the same risk with breast cancer as compared to estrogen and progesterone together. And it may be also different depending on the type of progesterone, as natural progesterone may possibly have a lower risk of breast cancer than with synthetic but progestins. But this evidence is still, I would say, evolving. Let's look at breast cancer risk, though, in context to other risk factors for breast cancer. Um, The hormone therapy, this is hormone therapy use for more than 5 years. So this is the one in red. And you can see other risk factors for breast cancer. These are some modifiable risk factors here. And then there's some non-modifiable, such as family history, for example. What you can see is the use of hormone therapy, estrogen, progesterone for more than 5 years is very comparable to some modifiable risk factors, such as drinking alcohol more than 2 drinks daily, for example, post-menopausal obesity. So you can see that things that we can address, we can help reduce our possible risk. And we should be addressing our lifestyle considerations, such as reducing the amount of alcohol, quitting smoking. It's not on this graph, but quitting smoking and maintaining a healthy weight are all going to be important for bone health. Now, there are some women who cannot use hormone therapy. They may have some of those contraindications I was mentioning, or do not want to use hormone therapy. And we do have some non hormonal prescription options, and these have studies to show their benefit. These are the options that we could consider instead of hormone therapy, and you may see these being prescribed. It could be antidepressants. Very commonly, we see things like some of the SSRI antidepressants, or even antidepressants like venlafaxine, for example. Gabapentin is also sometimes prescribed, and gabapentin can also help with sleep, so it can actually have another benefit. Now, you might see clonidine and oxybutylin are some of the other options, and unfortunately, I don't have time to go into too much in depth about each of these options, but maybe there's some questions. What about complementary and alternative therapies? As I get so many questions about that as well. And unfortunately, I could spend like hours on this alone, but we just don't have the time. The guidelines indicate that the most evidence for complementary therapies, and that's with the best evidence on this slide, is with cognitive behavioral therapy. It has great studies, not only for sleep issues and mood, but it can also help with hot flushes and night sweats. And even mindfulness based programs, such as like mindfulness, stress relief programs type of thing, can also be a benefit. There is some evidence for phytoestrogens. Phytoestrogens are plant-based estrogens, and these include soy-based products. They can be soy protein, isoflavones that you can purchase, and even red clover, for example. They have some evidence, so they have mixed evidence. What we mean by mixed evidence is some studies have shown benefit and some did not. So it's really hard to kind of say for sure. However, if you have some mild symptoms, these can definitely be options. And there's some evidence with acupuncture in the same way, kind of mixed evidence. Now, there's many natural health products promoted for menopause, and I do not have time to discuss these in length. These include things like black cohosh, Dong Quai, evening primrose oil, and a number of others. Unfortunately, overall, when you start looking at the evidence, most of these do not have the good studies to promote their use, and that's sort of the summary of the guidelines and their recommendations, they don't have the good evidence to promote that. But if you have questions about that, I would recommend talking to your primary care provider or your pharmacist, who may be able to assist you on more of those questions. So what can you do to have a healthy menopause? What can you do to empower yourself during this time? First, educate yourself. Become informed. What kind of symptoms are you having during the menopause? What are you experiencing? What menopause phase are you in? Going to sessions like this webinar, and there's many similar ones that are being done for menopause right now. Start the conversation with your healthcare provider. Mention what you're experiencing. How is it affecting your daily function? Know your options. For example, we've done a quick overview today, but it gives you a place to start, but know which option would be best for you, what would work best for you. And consider long-term health, the cardiovascular disease risk or your bone health risk. So how do you start that conversation? Well, you just start. Discuss the symptoms you're having and how this is affecting you. There are tools out there that you can use to help you with the types of symptoms you're having and to be able to share that with your provider. The Menopause Foundation of Canada has a symptom tracker, but there's others out there as well. And there's apps, that you can download. You can download the symptom tracker, record it, and take it to your family physician to talk about. Remember just to advocate for yourself. Symptoms you are having, what options you may be interested in. Menopause is a time to pause and just reflect on your overall health, not only symptoms that you're having, but your long-term health as well. Make sure you continue to screen for health issues. Just make sure you get your blood pressure checked, your cholesterol checked, your cancer screening, including breast and cervical cancer screening, and look at your risk factors for bone health. And if you need to have meet the criteria to have a bone mineral density, depending on your age and what risk factors you have. Address your healthy lifestyle choices. And I sound like a broken record, but it's important to keep in mind quitting smoking if you are a smoker, limiting the alcohol intake, regular exercise, balancing our diet, maintaining a healthy weight, stress reduction, and finally, sleep hygiene techniques all are going to be of benefit. Now, I did talk a bit about misinformation in the beginning of this presentation, and I wanted to just highlight how to look for misinformation. And this isn't anything earth-shattering or anything new for you, but I just wanted to mention about how to look for those red flags, because this is important when you're looking at something and trying to decide if this is the right approach, or should you, believe what you're seeing, for example. So look and see, is there a promise of fixing everything? Is it going to fix all your problems? Is it going to fix your mood? Is it going to fix, everything that, you're dealing with, your fatigue and you're tired? And, is it going to fix everything that the promise of that? Does it use certain words or imagery that oversimplifies or is part of marketing? For example, natural, anti-aging, balancing. These are kind of words that are often used, and just taking a look at that. Use of strong emotional language to bring the emotional part of you. The fact that they have no expert sources or references cited, or they're just not really good references. And also always question if it does not go with expert consensus. What do the experts say? Why is it different that the experts have different opinions? And is it selling you a product, and making claims that do not really have the evidence to support their claims? A good source is a website called Science Up First, very helpful website for general misinformation in Canada and how to look at misinformation. It is from Canada's experts from across Canada, a group including Timothy Caulfield, I believe, started it. And they did one on hormone therapy recently. I was one of the reviewers, but it is a good resource. So where can you go for more information? And I do want to do a plug in for Canadian Menopause Society. Um, We are currently updating our website, and we do currently have information on there, some good publications, some good information for the public. And so, it's a good site to go to. We also do a lot for health providers as well, and have some great information for health providers too. In addition to Canadian Menopause Society, these are some other very helpful websites too that provide you with evidence-based information. The Menopause Foundation of Canada has a great website. They do a lot of wonderful work for advocacy, and another great place to go to. Society of Obstetrics and Gynecology of Canada, or SOGC, has menopauseinu.ca. Great information too, and nice and simple and easy to follow. Some very good information. Um, the Menopause Society was previously NAMS, have a lot of good information for the US, but also for Canada. International Menopause Society, or IMS, has a lot for the world internationally, but we follow a lot of the similar aspects of international menopause and the recommendations. And then finally, of course, Osteoporosis Canada, the place to go for your bone health information, one of my favorite sites. Another really handy website I want to make you aware of is the MQ6 website. And a colleague of mine who's on the board of directors of the Canadian Menopause Society, Dr. Susan Goldstein, developed this website. She developed it for healthcare providers, but also there is a section on for women as well. And it's to help individuals go through the process. For healthcare providers, help with assessment and making treatment decisions. And for women, it also helps them identify what kind of symptoms they may be having and what may be an option for them. And so there's some really great information for you. You can go through the algorithm, and you can take it to your primary care provider, your family physician, to discuss that with them. So some final thoughts I want to end with. Let us change the narrative on menopause. Menopause symptoms are common and affect a woman's life. Unfortunately, many women are not getting the support they need. There are a number of options to help manage symptoms, which, is really reassuring. There's more coming out. Not all women will need hormone therapy, but those with bothersome symptoms should consider hormone therapy. And I think it's important to know what you can do to become better informed and know your options. Empower yourself, advocate for yourself for menopause and beyond. And I think we have some time for questions. So I'm going to stop my share.
Hi, Dr. Yuksel. It's Tracie again.
Hello.
Thank you
Hi,
so
Tracie.
much. Hi. That was
Hi.
amazing. And I
Oh, thank you.
know that we have just touched on the very beginnings of the information that we're all looking for on menopause. We do have quite a few questions, so we do have time for a few. Just to answer a couple, this is being recorded. So you've all registered. If you're watching currently, you'll get the OC replay in your email at least by tomorrow. So you'll be able to rewatch the webinar. And the other thing is we know that there's more to discuss, and we're working on other educational pieces that we can share with you in the coming months. But let's jump into the questions. Dr. Yuksel, how long can someone use hormone therapy?
Yeah, that's a really good question. I get that question a lot, actually. Um, I want to kind of reassure women that there is no specific duration for length of time for use of hormone therapy. There is no 5-year cutoff. It's based on the need of the individual, and if they're still having symptoms or other benefits, then they can continue to use hormone therapy. I also want to reassure that just because someone turns, like, let's say 60 years of age and they started in their 50s, doesn't mean they have to stop. The 60 time frame, or that 10 years since their menopause, is to start hormone therapy, not to continue. And women can continue into their 60s if they're finding that they have the benefit. So really, it's an individual decision. I usually, in counseling women who were coming to our clinic, is when they got started on hormone therapy, is just think about the decision, reassess every year if you want to continue. So just think about it every year, just reassess that if that's the right option for you. And if it is and you're seeing the benefit, don't worry, you can continue on.
Okay, great. Now, going along with hormone therapy, is there a right dose for hormone therapy? And what about for bone health and or preventing fractures?
Yeah, so when we're starting off with hormone therapy to start, let's say we're using it for some hot flushes, night sweats, and sleep issues. Usually, we start what we call a low to standard dose of estrogen, for example, and um, usually that is, if you're looking at oral estradiol, it's 0.5 to 1 milligrams of oral estradiol. And if you're looking at a patch, for example, it's 25 to 50 micrograms of a patch that we would start. And the patches are applied twice a week, for example, and then the orals every day. So that's an example of where we would start. Sometimes we might start at 50, sometimes at 25, just depends. But that's the general dose. And then we would adjust it based on, are you seeing improvement? Or are you starting to have side effects? And we would adjust the dosing, and normally we do have to adjust things around a bit. We have progesterone doses is to match that and balance the estrogen doses, but it's, as far as the dosing for symptom improvement and those things, we base it on the estrogen and then balance it with the progesterone. For preventing bone loss, the lower doses will help prevent bone loss. However, to prevent fractures, you need at least, and if you're looking at oral estradiol, you need at least 1 milligram of estradiol. So that's estrade. Estrase is the product, or at least 50 micrograms of a patch. And if you're taking estradiol, it's at least 2 estradiol pumps a day to prevent fractures. So you need a standard dose to prevent fractures.
Okay, super. And can hormone therapy, can it increase libido?
Um, that is a good question. Hormone therapy can, by helping with the vaginal symptoms, it can improve libido in that way. So if you have a lot of vaginal dryness and painful intercourse, and it's been going on for a while, and you start to lose your libido because of that, then you will see an improvement in libido. Now, if somebody has low libido, one of the things that we do consider is using more of a transdermal product through the skin route, because oral estrogens can actually increase what we call one of the globulins that binds to testosterone, called sex hormone binding globulin. It binds to testosterone, can lower testosterone, so it can affect libido. So by using a transdermal route, it doesn't do the same thing. So we would preferentially use a transdermal estrogen, and you may see some benefits with libido with that. You might feel also just from not feeling as tired, maybe you were sleeping as well, and fatigue, and it's going to affect overall libido. Now, libido is a lot more complicated than just the use of estrogens. There's other potential reasons for libido, so it may not solve all libido, but low libido, but it may help a bit for some of these other reasons.
Okay, and kind of in that same area, an individual has written in that they've been prescribed Vagifem 10 for dryness and discomfort during intercourse. The warnings and precautions do state stroke and probable dementia as possibilities. Is this something this individual or anyone should be concerned about?
Yeah, that's such a good question. And unfortunately, the vaginal estrogen therapy product monographs all have a class description, or a class, sort of those red box or black box, not red box, black box warnings for estrogen therapy. So things like, you know, the fact with, you see that with systemic estrogen, for example, the fact of, the concern of, the possibility of stroke or cardiovascular disease, or, whatever, that is not the case with vaginal estrogen therapy because you're not getting the same systemic levels. It's mainly a local effect. There's such small amounts of vaginal estrogen in those products that it usually gets metabolized before it gets into the body in the right way, right? It's such a small amount. That is being absorbed. And so really the contraindications are not the same. So women who've had a blood clot, if breast cancer, even breast cancer survivors can use vaginal estrogen therapy. The only one is if they were on aromatase inhibitors, then we would avoid in that setting with vaginal estrogen therapy. And there's other products with that. But someone even who's on tamoxifen can use vaginal estrogen therapy. If someone's had a cardiovascular event or, in the past, they can use vaginal estrogen therapy as well. So it shouldn't be the same concerns. Unfortunately, the product monographs have not changed. Now, there was some work being done in the US to change the ones from the FDA, but it just never, they still have it in their black box warnings in the US as well. So.
Okay, great. So I actually have a few different types of questions. They're all around the same theme. If someone has started menopause early on, or if they've begun menopause and in both scenarios, they have not been offered hormone replacement therapy, and now we're looking at, 8 to 10 years after, are they still a candidate for or hormone therapy?
Yeah, that's a good question. And it's a hard one to answer just, in this session, because I think the best thing to do is to talk, and if it's somebody who is asking for themselves, is to talk to their primary care provider to find out, if they're still a possible candidate, because the more time away from, without estrogens, the possibility of risk is there, especially if it's more than 10 years. However, that's not a blanket statement. And I think you need to really individualize it to the person, like when they actually went into menopause, at what age, what that risk would be. So I think it's considering it on a number of things, and then what are the benefits they're going to see. So I can't make just a statement on that, but it's sort of really, I think it's a discussion with their primary care provider, or if they're seeing a menopause specialist at that time.
Okay, great. If someone is overweight or obese, is hormone therapy safe for them?
Yeah, so hormone therapy can be used in women who are obese. My recommendation, though, would be to use a transdermal route, either the patch or the gel in that setting, mainly because depending on how much weight they have, there is a risk of blood clots with obesity. And so by using the transdermal route through the skin, the possibility of less risk of blood clots compared to an oral estrogen is there. So using a transdermal product would be preferential. So it's not a contraindication just because somebody has obesity or is obese, but making the right choice, the type of product, such as a transdermal product. And if they just have vaginal symptoms, for example, then just using vaginal estrogen therapy or one or the other. There's some newer vaginal estrogen, not vaginal hormonal products out there as well. So using something like that is totally option.
Okay, we only have time for like two more questions. So, and this is so great here. So as women go through perimenopause, what should they start doing to avoid any osteoporosis issues in the future?
Yeah, another really good question. Thank you, everybody, for the questions. These are fantastic, and I see there's lots of questions in the Q&A too. So I love the engagement. So if you are perimenopausal or even just recently menopausal, it's really good to be looking at your bone health overall. Identify if you do have risk factors for osteoporosis. Osteoporosis Canada has some great information on their website to look and assess your risk factors, and before you reach menopause or in the first number of years after menopause or and beyond, actually. But look at those risk factors, to see. So things are like if you've already had a fracture, a fragility fracture, especially, that might be at risk. You may need a bone density because you had a fracture already. Family history, if you've had, especially family history of parental hip fracture, long-term use of certain medications like glucocorticoids, like prednisone, for example. If you're a smoker, if you have medical conditions like, rheumatoid arthritis or Crohn's disease, for example, or if you went into early menopause or premature menopause, these are all risk factors, and there's others too. So just going to Osteoporosis Canada, looking at those risk factors, talking to your primary care provider about that. Do you qualify for a bone mineral density? If you're 50 years of age or over and have some of these risk factors, you may qualify. Looking at exercise, balance and functional training, resistance and strength training at least twice a week for each of those. And calcium, making sure you're getting adequate calcium, mostly from the diet. But the recommendations of Health Canada, for example, and now with Osteoporosis Canada as well, 1,200 milligrams of elemental calcium, per day, and adding supplements if you can't get it in your diet. And then vitamin D, there's been some changes with the vitamin D amounts, recommendations. Osteoporosis Canada now is following Health Canada recommendations, but at least 600 international units per day and up to 800 if you're over 70 years of age. Taking at least a 400 international unit vitamin D is the recommendation for that. And then if you have, other risk factors like smoking, quitting smoking, avoiding excessive alcohol intake, limiting caffeine intake to less than 4 cups of coffee per day, for example, and looking at all those lifestyle things are all important. And I think we may be out of time now.
You know what?
That
That
was a
was
longer answer.
No, it was all wonderful. And we have a lot of people, just so you know as well, lots of people are saying how useful all the information you've provided is. I'm going to thank Dr. Yuksel, and I'm just going to share my screen here. Just to let everybody know, there are other resources on the Osteoporosis Canada website. There's a calculate your calcium tool. We actually have a new tool coming out within the coming weeks, so that will be showing up pretty soon. We have our podcast on a variety of topics, also the blog. And as I said before, this webinar is being recorded, and this, along with other webinars, will be available on the OC Replay webpage. You can find all of that at osteoporosis.ca. Hey, our next webinar is going to be a cooking demo, and our featured ingredient is Greek yogurt and pasta. Yes, I said and pasta. So there you go. You can come and see how high protein yogurt and calcium is going to bump up those nutrients in an everyday dish. And you can register for that at osteoporosis.ca/event. So you can get all the information you need. If you are not already subscribed to the National e-newsletter, all you need to do is visit the homepage of the Osteoporosis Canada website, click subscribe, and we will be sure to send you information and updates as it becomes available. I would like to thank Dr. Yuksel again for this wonderful webinar. I'd like to thank everyone for registering and for all their amazing questions. Lots more information we're working on to share with you. So visit osteoporosis.ca, stay connected, and I hope everyone has a fabulous day. Take care, everyone. Thanks again.
Thank you.
Bye-bye.
Thanks so much. Thank you. It's wonderful.